Hello from Crete. I hope everyone is enjoying virtual UEG week. I'm Dr. Foteini Anastasiou. I'm a member of the Education Committee and represent the European Society for Primary Care Gastroenterology. I'm pleased to be here with you for the next 60 minutes. I hope you will be pleased too after that. Today I'm joined by my colleagues, Dr. Marina Berenguer, Professor Christos Lionis, and Dr. Alanna Ebigbo. And we identified this session as the hotspots of equity in medical care. Rather, we will discuss the inequity, the burning question of inequity in medical care. We want you to share your views and please discuss with us why medical equity is unmet in current clinical practices. I would like now my colleagues, Dr. Marina Berenguer and Professor Christos Lionis and Dr. Alanna Ebigbo to present yourself shortly with a focus on your expertise, please. Marina.
Well, yes, hello everybody. It's really a pleasure to be here today and to discuss, I think, this extremely important topic. It's been something that I've been interested in a long time. I'm a hepatologist. I work in Valencia, Spain, and I've been mainly interested by the problem of inequities in access to liver transplantation for several years.
Professor Lionis.
Thank you very much, Dr. Anastasiou. I feel very privileged in serving this interesting joint round table. I'm professor of general practice family medicine, and I had the privilege in representing the European Society Primary Care Gastroenterology in the scientific committee of UEG. And I think that this subject is timely coming, especially during pandemic. And I'm very keen in discussing many determinants, either predisposing factors or enabling factors may have an impact on the subject we're discussing, that means medical equity. Thank you.
Okay.
My name is Alanna Ebigbo. I'm an interventional endoscopist based in Augsburg in Germany. I'm a member of the International Working Group of the European Society of GI Endoscopy. And we have focused on global inequity and inequality and tried to partner with African colleagues and African gastroenterologists with the purpose of also producing cascade guidelines. And I'll be talking about these today. Thank you.
Thank you very much. I would like now to ask online delegates, if possible, to post your questions in the Q&A tool. Vote when you're asked to, and tell us what you think about the hotspots we are going to discuss. We would like you to see the image in your screens and think about it. You will see people from almost all races, gender, different phenotypes, age, and so on. And we would like you to think who of these persons you think you will get the better treatment. Is it difficult to think? Would it be an old colored lady or a young white male receiving the preferable treatment? We are talking about the major challenges in equity in medical care and our role as medical doctors in protecting equity in the way we can. I would like now ask Dr. Berenguer. Marina, please do introduce us in the first hot major obstacle in health equity. Marina.
Okay, so yes, if I could have my next slide, and I'm going to really talk about one topic that I think there's been in hepatology. There's been an interest in understanding how diseases affect differently the two sexes and how they affect also gender. And in addition, how gender also has an impact on liver transplantation allocation process. So to begin with, I have a question that I think it's very interesting. So if you have these two people next to you, your next two patients, they come to your clinic, and these are the two patients that you see. They are in a liver waiting list. So who do you think will get the next liver offer while being in the waiting list to be transplanted? And we have two persons, both have NASH-related liver disease, both have the same age, and both have the same MEL score of 26. And the three potential responses are the men, the women, and either way, no idea. So please, if you could vote and think about these two candidates, men and women. They have a NASH-related cirrhosis, decompensated cirrhosis, quite sick. They have a MEL of 26, and they're both same age.
Okay.
So I think, let's see what the responses have been. So in general, there's been, nobody thought that the women would be transplanted first. 2/3 thought that it was going to be the man, and then 1/3 no idea. So if you can move now to the next slide, and the next slide, okay. So this is data that somehow summarizes really lots of papers that have been published in the last 10 years. Just as a reminder, the MEL score was introduced 10 years ago or so that access to transplantation would be as equitable as possible and just and fair and really clear among anybody in the waiting list. But it was quite soon realized that in fact women are 20% less likely to undergo liver transplantation, despite the fact of introducing a very fair MEL score, which is based on laboratory variables and which was thought to be as transparent as it could be. And the idea that why men and women in the waiting list and having the same characteristics may be transplanted at a different time points and with some inequity, with women having less chances to be transplanted, appear to be related to three different aspects. The first thing is that men have more indication of liver cancer, and in general, hepatocellular carcinoma, they get extra points, exception points, and so these, typically speaking, provides some kind of benefit. The second problem is that women have less muscle mass, and this relates to less creatinine levels, and this in turn results in lower MEL scores, so that for the same MEL score in a woman and a man, in general, women have a much worse kidney function, and thus they have higher mortality, and thus in general, women drop out from the waiting list more often than men because of higher mortality, despite having the same MEL score. And finally, and I think this is very interesting, is that overall women are shorter, they're more petite than men. And then when there's offers from the waiting list, in general, the offers come from men that are bigger, that are larger. And so it's usually these offers are turned down more often by the first person in the waiting list that is a woman compared to men. So here we have like three examples that explain discrepancies in access to liver transplantation. And there's been a lot of research in what we could do. And very interestingly, just this month, there was a publication from the United States, from Lionis, publishing that they are going to change the MEL score. This is undergoing review now by the Lionis panel. And there's a new MEL 0.3 score that was just recently created and just recently published in Gastroenterology. And in that MEL score, gender is going to be added to the MEL formula. As you all know, the MEL formula is based on bilirubin, creatinine, and INR. And now this MEL formula will be updated with the introduction of data on the gender, whether it's a woman and a man. And by doing so and adding also albumin, the authors found that this could lead to a significant reduction in these discrepancies, and potentially in some years from now, we could perhaps erase this sentence that women are 20% less likely to undergo liver transplantation. So I think these are very good news now.
That's great, Marina. I would like to ask our panelists if they have to comment on that, if they agree with this opinion, if they have something else to add according to their expertise and experiences. Please, Professor Lionis and Dr.
Very shortly, thank you very much, and I fully agree with the approach of this excellent topic that has been introduced. I suppose also that we needed also to address gender discrepancies based on the differences on illness behavior. But this issue on illness behavior could be discussed in the second question when having the chance in a little bit analyzing the differences in utilization system. Thank you.
Okay. Alanna?
I think it's so remarkable. Instinctively, I would think it has to be equally shared. I would never believe that the sex should play a role or plays a role. And I really find it interesting the points you give to explain why it does play a role, and there is also data accompanying it. So thank you very much. I'm quite enlightened by this.
It's great. We can go on now. There are no questions from the audience. We can go on to another the next top expert will present you with a very crucial topic, inequity. Please, Professor Lionis, the floor is yours now.
Thank you very much. Very much appreciate. Next slide, please, or the question. I'm planning, as already stated, I'm coming across so-called determinants of illness behavior. That means the use of healthcare services. That's now needed in giving more light on the potential factors that may have an impact on the use of healthcare services, with the main aim to having an understanding about discrepancies or inequalities in that issue. And that's the question, is asking, could you please define 3 factors that may have an impact on the use of healthcare services in generally, whether primary care services, hospital care services, or going to your personal doctor? That means to what extent, educational level, income, country origin, age, or chronic disease. You could choose one or more that some of the questions, more than one, could satisfy the response to that question. Who can start? Okay, that is quite interesting that we divided, consider that's the important determinants of illness behavior in looking for health care services, education, and age. I think that you can find the response in the next slides, or some important theory that all the medical doctors, but all the healthcare professionals needed to have in their mind. Next slide, please. Okay, I think that is a slide for one publication, which just reminding the important Anderson model. The Anderson model is saying that the factors that may have an impact on the use of healthcare services could be divided and grouped in 3 domains. The first is the so-called predisposing factors. Predisposing factors means the factors is inherently associated with the individual, included demographics, as for instance the age of the person, and then also social factors, means the social determinants of healthcare utilization. Enabling factors are very, very important, a group of factors, and included economic factors that may have an important impact, especially just define the so-called isolated groups or vulnerable groups in many times that have not any use of many healthcare services independently if they provide it. And the third, and means need, means in relation to the health outcomes that's reflecting the person's healthcare needs, as reflected in chronic morbidity, or in the well-defined needs for approaching or using healthcare services. I think that this is a very important slide, always having in our mind that potentially certain people are not visiting us, not because many other factors, as a gender issue, for instance, clearly described, but also because there are important determinants of healthcare utilization. Next, please. I think this is question 3. Potentially, Dr. Anastasiou, if you have questions, potentially included question 1 and question 2 and question 3. The third question is also relevant to this subject. Do people living in rural areas are having a higher risk of developing cancer than people living in urban areas? Name 3 possible factors that could explain why this group of people is at risk. Because the people living in rural areas have a low health literacy, or because there is a high diversity in perceived risk, because they presented barriers to access, or other genetical factors or lifestyle factors may have an impact on this potentially or assumed discrepancy in regards geography of the people, rural versus urban. You can now vote.
Important questions for all doctors.
Yeah, this is a very interesting question. You know, I think it's not that easy. It's a question that really makes you think about it.
Yes.
Because it is, I think, implicated with many other concepts. So
I was also wondering whether you can categorize these answers also in predisposing, enabling factors, like you described in the previous slide.
Yes, wonderful comments, and I'm very grateful for your commentary. I think that this is a very tricky question. Firstly, because it's difficult in giving an explanation to question 3, and also would be excellent if you could match the potential factors with the Anderson model. That means low health literacy and access barriers potentially having. And just the next slide, in giving some input from the pragmatic world. Next slide, please. Next. I think this slide is very important. And our research team at the university and medical faculty, we having very many interest and a lot of project in studying further, because perceived risk and health literacy, that's may consider as one of the major determinants of the health behavior. This is also one important statement in the recent Lancet publication, when we European team are focusing on a European strategy towards this pandemic. I think both concept, perceived risk, and health literacy, we just referring to the capacity one individual has to look at potential information or critically appraising it, or consider that is a part of the health behavior that potentially should be undertaken. I think that both concepts should be reviewed frequently and carefully, and potentially could give us a response to why rural people are having an increased cancer rate in comparison with urban people. And to having an understanding to exactly the data the real world is giving, I think that you can find the next slide. The next slide is for one master thesis, which just recently we had the pleasure in discussing in our medical faculty. It was it was a thorough exploration of the data from our digital cancer registry we have developed on the island of Crete. And we discussed and seen so many cancers, including lung and bronchi, prostate, colon, skin, and liver, and also another associated cancer. You can identify that a relative risk, the odds ratio, is higher in comparison with an urban area. And the most important, when you looked back to the data 20 years ago, when comparing rural and urban people, we identify that rural settings, it was just presenting only stomach cancer at a higher rate in comparison in urban. That we have during last 2 decades enormous increase of the probability and possibility a rural person just developing a cancer. And that is, of course, under exploration and under investigation. I think that's from my side, and I'm very grateful in having comments or a question. Thank you.
Okay, I would like to listen to the comments of our colleagues. We already talked about a little bit about the differences between rural and urban areas and health literacy, which is very important, and how we can add to this as doctors. Please, Marina and Alanna, your comments.
Okay, sorry, Marina, you go ahead. Sorry, you go ahead. Okay, I was so enthusiastic about what I wanted to ask. I'm trying to understand this, Professor Lionis. The information you're giving us is that the risk to develop cancer is higher in rural areas, not the risk of coming later for diagnosis.
That was my question exactly. Because I feel it's really striking. I mean,
yes,
it's really the first answer.
Exactly. Yes, we have in the data from both morbidity and mortality. That means the risk in being diagnosed, because we based on diagnosis that we gained from the cancer registry. And also we're talking about the risk for a death from a separate. That means in both morbidity and mortality coming across to the same results. And that's for us, it's a bit was unexplained, because there are many specific cancer diagnoses that are higher, and needed to just draw more our attention and for introducing a big discussion at the moment, identifying explanatory factors.
And I think this is really impressive, because I would have always thought that in rural areas, they have a much more better habits of life, at least around in my country. I think they tend to eat better. They have access to fruits, to vegetables, it's not everything, they are more relaxed somehow. It's not, so I'm really struck by this. So I wonder if you have data on whether this is all related to metabolic factors. Is it related to obesity? Is there a relationship with obesity, which I think is really, hitting different parts of the world differently? And obesity is being extremely important in rural areas, as far as I understand.
Yes. Thank you very much, Marina. It's excellent comment that we have in data from cross-sectional studies already published that metabolic syndrome, especially due to high obesity rates, which more predominant in rural areas, that's an opposite that we have known from since decades ago, when a Mediterranean diet and healthy lifestyle was more predominant in rural areas. That potentially now we have in front of us an enormous change of the patterns of morbidity and mortality, and that's needs to urgent actions to change this profile now.
Unfortunately, we have seen that in rural areas. Almost a decade ago, we defined that children in rural areas had more obesity than a decade before. So, and comparing to the urban areas of Crete, and imagine Crete with the Cretan diet. So this all is an element of the changes in lifestyle, and indicates that thorough actions have to be taken by primary care and public health sector. That's the need for us, or what we can add to this, and lower the inequality in access. That's our role in this session. So thank you very much all for your comments. I will now hand the floor to Alanna, because there is another concept between developing and developed countries, and he's a good expertise in this and guideline implementation. Alanna, thank you.
Thank you. I'm really privileged to be part of this group and to be able to discuss these topics here. I initially mentioned that I'm a member of the International Working Group of the ESGE, and we published a number of cascade guidelines. Cascade guidelines are guidelines which are taken from the original guidelines, original recommendations, and adapted to lower resource settings. That is the background of the cascade guidelines. What the ESGE did is we identified the top 3 indications for endoscopy in lower resource settings, and then chose these existing ESGE guidelines, and together with African colleagues and African gastroenterologists, we rewrote these guidelines to suit to these settings. So my first question is, do you think that a GI guideline can be adapted to lower resource countries or to lower resource settings? So if I understand well, we have a word cloud, is that right?
Yes. So people can answer there, please. Okay, we have to wait for some seconds before the answers come out.
Maybe my co-panelists can give a quick answer whether they think, number one, is this necessary? And number 2, is it possible?
I think it's always, everything is possible. So this is also possible. Whether it's necessary, I think it has possibly 2 sides. I mean, up front, I haven't really read that much about it, but I think it's probably necessary. You can't just be talking perhaps about guidelines that are using huge equipment for perhaps rare diseases, and what you really need sometimes is just to focus on the majority and what's more frequent in our society, and that should be kind of there's always the economic that goes together with what we do. But at the same time, if we adapt guidelines, we may be losing the opportunity to push the governments in many places to be more proactive, to develop their the best healthcare quality that can be achieved.
That's an interesting point. That's an interesting point.
Thank you very much. You raised a very important question. I suppose that this is possible, but after adaptation. And when I say adaptation, I'm saying cultural and organizational adaptation means take into account especially the different patterns of illness behavior, but also expectation, wishes of the patients. That the patients in low-income countries have big differences in terms of wishes and expectation, and also needs. And the second is just organizational adaptation, means that the setting and the context is quite different. That potentially, that is saying, okay, yes, but after careful adaptation, that should be included in the mechanism of transferring the guidelines in another setting. Thank you.
Okay, thank you very much. Those are beautiful comments. Yes, perhaps, yes. So these are the 2 words that are coming in the word cloud, yes, and perhaps. I must say that what we did is we worked together with African colleagues after identifying these top indications in a multinational survey within these African countries. So even though it's difficult, like Lionis, Dr. Lionis, Dr. Berenguer have said, if you identify organizational, structural, technical, economical issues, then it may be possible. And the second question is, does it make sense? So maybe we go back to my next question. The second question is, who should adapt these GI guidelines for lower income countries, and who uses them? So the question of who should adapt them, I think I've already brushed on it briefly. It is very important, and it's crucial. It's crucial that these guidelines be adapted by colleagues who work in these countries. First of all, they understand whether it's necessary, whether they will be making use of them. And secondly, we remember that we are not talking of one geographical region. We're talking of a vast and diverse geographical regions with various levels of expertise and various levels of resources. I'll give an example. When we were in Ethiopia for our last training course, we performed a lot of esophageal band ligations because of portal hypertension due to schistosomiasis. Now, this is an illness which we hardly see in Europe. So most of our varices were esophageal varices, but unfortunately, we had one patient with very large gastric varices. So we were very good at esophageal band ligations, but for the gastric varices, we needed cyanoacrylate. Unfortunately, even though it was an expert center, a tertiary care center, we did not have cyanoacrylate. So these are the various levels of resources that are available, and even then they differ within these centers. So maybe we can go to the word cloud if it's available. And if not, maybe I can, oh yeah, it's difficult, and exactly. It's a difficult question, correct? And I think the experts from the individual countries need to be involved. Exactly right. So do we have a third question?
In fact, if I may say,
please.
Somehow everybody adapts the guidelines. Even at we adapt the guidelines, even though it's not in a country matter, it's a hospital matter, because not all the hospitals, as you mentioned, have the same equipment. And so we end up, for instance, we can't perform portal hypertension measurements in all our cirrhotic population as specified in several guidelines. It's just impossible. There's no man force here that can do this. I mean, there's like no human force. We don't have enough people to do the job. And so we need to adapt the management of portal hypertension to our setting. So somehow I think everybody is adapting the guidelines.
Exactly. Thank you. Thank you. That's a splendid comment. And Dr. Foteini, I think my time is over.
We can discuss a little bit more, and there is a comment on the chat about the topic that it's great, it needs to be discussed more. And
okay.
In addition to this, they are talking about the inevitable talk about patient safety. And it has to do with guidelines. It has to do with the approach to services. It has to do with literacy, health literacy. It has to do with everything. So we could maybe discuss a little bit about this comment, maybe how what we are talking about inequities in health has to do with patient safety in the end of the day. So I would like your comments on this chat comment, please. Professor Lionis, is that
there are many issues that needed to be discussed under the label of patient safety, and I'd like it to introduce next to this term patient safety the so-called health integrity. That is very, very important, especially in low-income settings. patient integrity is very, very much related with the quality and patient safety, but also with the patient rights. And that's the patient rights, health integrity, and patient safety is very, very important. And many thanks for that comments. I think that now making a bridge, a link between equity, patient safety, and patient rights, that's potentially during this pandemic is a central issue. Thank you.
Marina, please, your comments.
Yeah, I think I agree with Christos. I think as he mentioned, I think everything is linked. You know, it's like the question we were having on rural areas and urban areas. And it's also about the, I think what they were saying about what are our expectations. Also, the expectations are different in many countries, in many settings. And I think that has also something to do with patient safety. So I think it's all somehow mixed in many different many of the components that we are looking right now, because I think some really disparities in many things that we see, they're related to socio-cultural background, they're related to genetic factors, they're related to concomitant factors. So there are so many factors here that play a role, and this plays a role in inequalities in everything, and also regarding patient safety.
Maybe one word to patient safety in African countries where we have our partnerships or in lower resource settings. We notice that the enthusiasm and the motivation to perform endoscopy and endoscopic procedures in these GI units is very high. But it was important for us to understand the situation around the endoscopic procedure, which means, is there anesthesia? Is there a possibility for sedation? Is there a possibility for oxygen? Is there also an intermediate care unit or an intensive care unit that can follow up in case there's any complication? So these were also part of the cascade guidelines. These were points which we considered also while writing the cascade guidelines.
But do you think, just a comment, for instance, this has a lot to do on really how the society evolves. I mean, for many years and many years, at least what I can think when I was doing my residency, we didn't have all this anesthesia and everything, and people would do the whole, you know, even biopsies were done without ultrasound. Then in fact, if you look at the studies, many of the things we do towards safety of the patient, in fact, for instance, biopsy done with ultrasound or without ultrasound, the rate of complications eventually is not that, it's not different in mortality related. There may be a bit of higher complications, but it's some studies yes, some studies no. So I think what I'm saying is that I agree, it's very important, and we ask, and patients ask more and more about the safety, but I think this also has a huge impact on economics. Everything we do now, it's an immense amount of money, so that every potential complication is taken into the equation.
Yes, I agree.
This will lead to the, I think personally, that this ends up being the healthcare that they have in the United States. That is extremely expensive. If you compare the expenses of any of the biopsy, paracentesis, it's just like 5 times in the US, because in the US you could do a paracentesis, you need all these different items that need to be made sure that you've done. And perhaps it's, you know, the difference in patient safety is just that minor, and yet the difference economically is just humongous. And I think we also need to discuss about this.
Great. There is another question about going back to guidelines, because it was lost a little bit, the question. who should adopt guidelines and who eventually uses it. Okay, we have the guidelines, we culturally adapt them, and then who's using it? And what's the effect on people after that? As Marina said, that the changes in patient safety and challenges there. But do doctors use guidelines eventually, even if they are adapted to their environment? That's a key question to all of us.
Well, if the panelists can have a good idea on how to really find out how these guidelines are then actually being used. Maybe we can comment on this. What we did, what we keep on doing constantly is we speak with the national societies of these countries in which we have our partnerships, and we try to create awareness of the existence of these projects and of these guidelines, and try to find multipliers, multiplication doctors who spread the word that there is this project, that these guidelines are available. It does not necessarily mean that these guidelines are there to tell gastroenterologists in a country like Nigeria what to do. But they also have an educative effect, because you have the possibility also to compare the situation between different regions in the world. And then also make your own opinion. Like Marina rightly pointed out, not everything we are doing here is the way to go or the correct thing to do. So.
Because I think one point I think needs to be discussed. Guidelines, I think, is data that has been put together eventually based on the best of the evidence to come with a strategic approach to diagnosis and management of the patient. But it's not, you know, it doesn't have to be followed like completely like because, you know, human beings are I love the picture initially. We are so distinct. There are so many variables that play a role in how we respond to disease, how we approach disease. And so I think the guidelines are here to guide, to help, but they're not obligatory, compulsory things, I mean, you know, that we need to follow compulsory.
One of the subjects that usually we're missing when producing or translating guidelines, I think, is a strategy for implementation, and included the evaluation of the use of performance or the utility of guidelines. I think that is very important. The second is just important is that sometimes patients and consumers are not involved in the production of the guidelines. And that means we needed to take into account that the patients should be involved in any process of the guidelines from the production until the implementation. And also we needed also in discussing to what extent the produced guidelines should be properly to be adapted for use by the patient. I think that both the involvement of patients in the production of the guidelines, but also that patients as potentially recipients of the practical guidelines needed to be addressed. Thank you.
That's great one. Okay, I would like to ask now our audience if they could write in a couple of words the main reasons for them think it is challenging to approach equity medical care in daily work life. We will open this word now, and all the colleagues are invited to write their thoughts in it. And while they're doing so, I would like to ask, it was mentioned before, Professor Lionis, that about health literacy. And as a general practitioner working with, trying to develop, to make points in people how they have to screen for cancer, for CRC cancer, for other cancers and everything. What is our role in this, and our responsibilities on developing the health literacy of the people we have in front of us, how we can do it in everyday life and improve their aspects for health. Have you any suggestion?
I think that's a WHO clearly making simple suggestions. I think that any medical doctor should address the patients when during consultation with 4 or 5 simple questions. The first question, it is necessary having an understanding which sources the patient is coming across. That means from which sources the information come to the patient, because the patients and the people are now having many opportunities looking into the internet and identifying many sources of information. The second is just having an understanding to what extent patients have critically appraising the existing information, and to what extent the patients having an understanding that this guidance is relevant to the health, and just checking and exploring if this understanding or information that already the patient received, either from the doctor or from any other resources, that could be used in changing the behavior. I think it's a so-called issue of metallization. It's a logic flow of thoughts and thinking that the doctors should involve in asking the patient to having a better understanding, and then a little bit trying to motivate, as motivational interviews and other health behavior approaches, a little bit to try to adapt. Such type of logic is necessary. It's so very important, especially in this pandemic period, when having many people have not just received the proper information from the proper sources, but also just having a kind of hesitancy either in vaccination or protective measure. I think that such encouraging dialogue should be introduced.
Marina, is it different?
Well, I think, no, I completely agree. I think he really is, I mean, this is extremely important, but this means, I think that the relationship between the physician and the patient has to be extremely good relationship with a high degree of trust. And the problem is, as you mentioned, and I think the pandemic has been an example. I think I mean, it's very important that everybody has a basic understanding of everything, but at the same time, there are so many sources of knowledge currently and of data, of ideas. And you can't really tell a patient, no, go to the website of the society, and then they come with, I saw today a person just came to my clinic and said, I saw a study that PBC women that have more urinary infections, they die more than PBC women that don't, because they start looking at everything. There's a paper that has been, so the problem is how you select among that tons of data that is entering every day from many other sites, how you select the adequate information. And I'm afraid I don't have the answer. I have to tell you, it's like if I'm asked to talk about economy, there's like, where do I look for data on economy? You read in a paper, you read things and with some ideas. You read in another paper and it's completely different ideas. And I think in medicine, it's somehow like this. There's just too much data, too much information, and how to select the appropriate information for so many sources. And I really don't know the answer. I think it's very difficult.
Interesting. Okay, we don't have too many ideas or words, but interest is okay. It works for me. Okay, I would like to ask Alanna a little bit on this discussion we have started here, and we hope we have more people in it. How people react in a developing country about all sorts of things that we have discussed here. because we have here many refugees, and in order to discuss about their health and perception of health is different, because they have other problems to solve first, more crucial to their life, and then go for screening for all the rest. So I would like your opinion.
Yes, I think that there are 2 points that I'd like to make specifically to this question you brought up. The first point is also chipping in on what Marina said. The first point is the physician to patient relationship needs a lot of awareness on this topic. And unfortunately, at least in our country, in my country here in Germany, that awareness is not generally there. That and even though it may be there, that the patient is struggling with other issues, existential issues. Yes, he has he just had a varicose bleeding, or he has a polyp somewhere, but he's worried about being shoved back to a country where he has other problems. He would have other problems, and all of a sudden he disappears from healthcare, and the physician gets upset. So maybe that may be an issue of awareness for physician-patient relationships here. The second point is now going back to lower resource settings. The most important point I'd like to make there is to interact on an eye-to-eye level, not on a level where somebody is higher and the other is lower in whatever sense, whether it's economic, knowledge. There always has to be an eye-to-eye level in any partnership involving international or inter-regional cooperations or projects, because we learn from our projects that we do there, and at the same time our colleagues in these countries learn from us as well. So
I like very much this eye-to-eye approach. It's great. It starts from the kindergarten. You can have to approach the children, and then to all kind of relationship until the end of our life. It has been great to discuss here today with you. Unfortunately, we do not have many comments. Hopefully, we raise ideas and comments when they see it on demand. And we hope to go on with these topics. And it was a great idea from Marilena Arvanitaki, this topic, and I engaged it and they gave it to me. But it's you that made the difference in this discussion. To sum up, we discussed about inequities in health and our role as practitioners, and how gender and the geographical area you are born, whether it's rural or is sub-Saharan or not, plays a role in the access of health and plays a role in the outcomes of health. And most importantly, I would like, as a general practitioner, to keep in mind our responsibility in everyday life practice, that we have to raise this subject, and we have to the awareness of people and protect them in a huge system and an economical chaos, in COVID area, in earthquakes, in grid, in everything. So the role of practitioners is very high, and especially in primary healthcare. And one last comment from all of you before we close this session. What you...
my last comment is, I think that this needs to be worked in so many fields. I mean, we could start by working on inequalities in the healthcare workforce. This is a problem that we see. So there are inequalities in so many areas in the world, and disparities, and so many disparities. So I think, personally, I think that it's important at least to think about it. I was very struck by the data by Christos on the rural. I have never thought about it, this data that he showed about cancer. And I think I'm going to be more aware about this now. So I think the first step always is to be aware. So just that's the first step. And then the following steps will follow. But the first one is to be aware that these problems exist.
So, Professor Christos Lionis?
Thank you very much. inequalities, disparities, and patient rights are very important priorities for the current discussion, and many thanks to UAG bringing this subject to you these days. Thank you very much.
Alanna?
Yeah, my final comment is more of a plea. I would like to plead with we as physicians, we have a particular responsibility on behalf of our individual societies to look across our personal borders and boundaries, but also across our regional and national boundaries to understand our patients and understand our colleagues in resource poor or resource lower income settings better.
I think there is a lot of literature and the dissemination of information, as we have from universities to doctors like me in primary care, healthcare, and the connection with you, the experts, is very important in order to shorten out the inequalities and develop a better understanding of our patients. Thank you very much all for your comments and for your input in this conversation. Hope we'll meet again soon in person, probably next year. And thank you very much the audience, those who are looking now and those who are going to look at it later. And we will welcome any comments even in a later response. Thank you very much.
Thank you.
Thank you. Bye.